Welcome to the Global Surgery Modifiers RT, LT, and 50 webinar. We'll talk more about where this comes from and exactly what's going on with this. Couple of things to keep in mind. We are here to focus on these particular modifiers, not on overall global surgery concept. The basic fundamentals was done last month, and then we'll move through a set of modifiers for the next couple of months. So if you ask me questions not related to RT, LT, and 50, I may not have time to address those, but please remember to watch our live events page and register for future upcoming stuff. If you're having any issues, I do recommend that you take down the number in the chat. This will just help you have it. Again, making sure that that phone number is present at all times. All right. What are we here to do today? Well, we're here to get a basic understanding of global surgery. Now, the reason that this is important is that you don't necessarily understand when to use modifier RT, LT, or 50 related to global surgery if you don't even get the global surgery concept. I will tell you a couple of comments or questions made during the registration process, which led me to add in the information that I did. We also do want to talk about the global surgery periods, why that's important, and then again, focus on RT, LT, and 50, but we don't want to neglect your questions. I do want to give you as much time as I can to get to the questions, but I will tell you we had a lot of questions submitted. Some of them were not related to the modifiers RT, LT, and 50, so we may not get to those. Don't fret though, there is more global surgery webinar modifiers coming up. Take a look at live events, watch for those to come out. I'm not sure that any more are posted as they aren't until the end of January, February, those types of things. So you might have to wait just a little bit to see it get posted. As a reminder, please review the legal disclaimer at the end of our presentation. It does give the CPT legal disclaimer. All right. So couple of things that keep in mind. We did add in some definitions and some basic information. This is designed to help those that ask for, they don't even understand what's included in the global surgery package and they don't understand what global surgery is. Those were two of the comments put into the pre-registration questions. There was a lot more in there, just generalized comments. So we thought, okay, let's consolidate that section. Let's make it into one item. And that's where this set of slides came from. So first, what is global surgery? Well, global surgery is a package. It is a single fee provided for a surgical service or another type of procedure that incorporates normal care. Normal care is medically necessary care. It is preoperative, intraoperative, and postoperative care. It depends on the number of global days and the complexity of the surgery as to what is included, whether it's pre, intra, or post, or just going to be the day of surgery. So it could be 1 day, it could be 11 days, and we'll talk more about that. It is for one provider. Now, there was a couple of questions that came in, and we'll talk more about that. The other item that came in is a couple of people referred to global surgery as a bundling. Global surgery is a bundling concept in that the surgical procedure actually incorporates the fees for the standard follow-up items. So you do a surgery, the fee for the stitches removal is part of that surgery. There's different things that bundle into that package. And that's what we're really here to talk about. So the global surgery package, sometimes y'all may like to refer to it as a bundling package, but that's what it really does mean. So necessary services. So first, what are the necessary services that are included in the global surgery package? Medicare does include certain services, such as a preoperative visit. This is the visit after the decision is made to operate. That's why there are times, when we'll talk about this in a different class coming in February or later, where January or February, sorry, where the class will be in January or February, where we talk about an E&M that is done and it's the decision for surgery. So yes, you will add a modifier. That is not part of one of our modifiers. There are also services that are intraoperative. These are included in the usual and necessary part of an integral surgical procedure. Last, there's postoperative, and these begin the day after surgery. So this could be your follow-up visits, you're related to recovery, post-surgical pain management, treatment of complications, miscellaneous services. This is where you begin to look at RT, LT, and 50 in some cases. What if the surgery was only done on the right, but the issue being addressed today is on the left? RT, LT. So we'll talk more about that and some of those different things because the global surgery package can be overridden by some of the modifiers. I was very specifically asked to include information on one provider. So one provider for Medicare is not a single person. One provider for Medicare, as it applies to global surgery, is a physician in the same group with the same specialty. So again, it's not one physician, but it could be multiple, but they're all working in the same group with the same specialty. That means that if that physician is unavailable to do the follow-up, but it's the same physician, or I'm sorry, it's the same specialty, same group, it would still be considered one physician. What are the settings that global surgery applies to? And there's a variety of different ones. They may be furnished in an ambulatory surgical, hospital in or outpatient, intensive or critical care unit, or a physician's office. And again, it really just depends on what the period days are, what the complications are, like how complex is the surgery, all of those. So global surgery on an overall concept can be done in any of those types of settings. But again, not all procedures can be done in all of those types of settings. So we want to remind everyone that. So by the way, yes, your settings do apply, and yes, you do have to follow those settings. Okay. The next set of questions that we got in relates to periods and what do the periods mean and where do you locate them? So I'm going to tell you what the periods are and how to find them, and then I'll actually show you on the CMS website some information that will help you. Okay, so first, global surgery periods begin with a 0 postoperative day period. Now, I want to point out that a 0 postoperative day means that it is everything on the day of surgery incorporated. There is no preoperative period and no postoperative period. The day of surgery does include a preoperative and a postoperative care. So if you put them in anesthesia, did you have them sit and wait for that to wear off? That's part of the postoperative care. When you went in, did you do a minor evaluation and management to make sure they don't have, we'll just use it as a cold or a sickness or something that would interfere today with that particular procedure? If you did, then you did you might have done some evaluation and management work, likely not to be super complex. So we do have more coming up. And again, I do want to remind everyone that there is more information coming up on some of those different types of things. So, but remember, a 0 means postoperative days. It means there's one global period, one day in the global period, and that's today, the day of surgery. Okay. This does apply to endoscopes, does apply to a lot of minor procedures, nail debridement, removal of contraceptive capsules, any of those types of things. So it's not as though it's an all-encompassing procedure. It's just a few minor things going on there. A 10-day postoperative period is a little bit different. 10 days means that we begin on the day of surgery, and then there are 10 days following the day of surgery, which are incorporated in which we expect normal care to happen. This could be such as suture removals or whatever you're doing there, right? We'll talk more about that. It does not give a day before surgery, though. So the total global days on this one is 11, the day of surgery, 10 following. The preoperative period is built into the day of surgery. So again, it's not a preoperative in terms of there's a day before or anything like that. It's a total of 11 days, the day of, and 10 days following. Okay. 10 days does apply to other minor procedures that are a bit more complex than the initial minor procedures we talked about. Acne surgery, some of the debridements, some of the skin tag removals, they're not as complex. Okay, so you want to make sure you're well aware of those two and which ones are going to be referred to as minor procedures. 0 and 10 day are commonly referred to as minor procedures. When you're looking at something that has 10 or 0 days, and I'm going to mention this briefly because we got a couple of questions on it. Modifier 25 would be reported should a significant and separately identifiable E&M visit be decided upon. The postoperative period does begin the day after, so 10 days following that immediate period. So if you're appending a modifier 25, it has to be on an evaluation and management code. Why do I say that? Because one of the denials that we're receiving is that you're appending a modifier 25 to a surgical code. This surgery is not a decision. It's not a separately identifiable service. Could you have an evaluation and management service which you appended a 25 to because you didn't know you were doing surgery today? Absolutely. So that's where we come in with that, okay? There'll be more to come on that if you attend the January conference for the global surgery and E&M stuff. All right, let's keep going on to the major days. And the major surgery post-operative period is 92 total days. That's the day before, then you're going to have the day of, that's 2 days, and 90 days following for anything related to that surgery. So that means your post-operative period is truly, your global surgery period is truly 92 days. Again, you do need to follow the modifier rules. We're going to talk more about that when it's RT, LT, and 50, just coming up in a little bit here. How does this apply? Well, this applies to any major surgery, and there's a lot of them. Here's just a few examples. So the more complex surgeries will always be given a post-operative period of 90 days, in which we do expect that certain evaluation and management services will be done. We also expect that there are other procedures that will be done. So again, we'll talk more about that as we come up against those in later webinars. Oops. I was asked specifically about some other modifiers that would apply. Somebody asked us about an indicator of YYY, ZZZ, and XXX. Now, please remember that we'll talk more about these. We'll talk more about these in just a few moments. Okay. So what we're going to look at is when we talk about those, though, is that they're set by certain things. So some of them will be concept doesn't apply, a variety of different things. All right, let's go here for a second. I did see a question come in, and I'm not sure what you're talking about, but we're referring to 90 days, but says 10 following. Oh, yes, right here. This bullet, this bullet should be a 90 days following. So 92, 10, day before, day of, 90 following. Thank you for catching that, Phyllis. That's great. Okay, so locating. This is where I had quite a few questions come in, and I thought, I'm going to go ahead and put a path here for you guys to follow, but I'm going to show you the path, and we're going to look a little bit more actually at the website itself for locating, because I think that's going to be what's best. So let's go ahead and do that, and then we'll talk about some of the different uses when we get to that point. So. All right, so first thing you have to know is you got to go to CMS's website. Again, global surgery is a national concept. It is not a local concept. Therefore, what we're talking about is on the CMS website in terms of locating global days, in terms of locating whether a bilateral surgery can be performed, which we would need for RTLT and 50, bilateral. So let's talk about where we're going to go from there. We're going to go to Medicare. That's what we're talking about. We're going to slide down to what I like to call payments. Now this is going to be in your left navigation column. Select the word payment and you will see the right side of your screen switch. I then go to the third item in the left column on the right side of the screen, and in the center it'll say fee schedules. All right, what are we looking for? Well, I'm looking for the physician fee schedule. Inside the physician fee schedule, there is a lot of information. So I do want to point out that they're doing some data collection on global surgery, but that's not really what we're going to look at today, but just so you know it's there. We're going to scroll down. We're going to look at the relative value files. And then inside the relative value files, these are updated quarterly. So when you look at these, that's why you have A, B, C, D. Every once in a while, they'll do an update between quarters, which is what the AR would represent, like this one in 2024. So it wasn't quite second quarter, which is in April, but it still affected things. So they do have a different one. I'm going to go ahead and use 2025, but I'm going to use D. The reason that I'm using that is that's what's in effect right now. Soon enough, we will have 2026 out there. Not yet, but they will be coming out soon. So this was updated on 9/11, and this is the release date for it. But again, they're not effective until this date. When we select it, it's going to say, hey, here's your file. Do you want to download it? And let me just put that on my desktop for a moment so you can go ahead and take a look at this. And this is a compressed file or a zipped file. So this is standard software that your computer has, which is what mine is actually doing here. And it is going to look like, sorry, it's taking a second to open here. It's going to look like this. Now, I do want to point out this bottom item right here. This is a great thing because this will help you read all the columns, and the actual document we're going to look at is directly above it. So it's these last two documents. Let's just go ahead and open this to give you a little bit of a concept first. Now, the PDF document, as I said, is kind of the understanding of the file. So it goes through, it gives you everything within this file. Now, this file has a lot more information than Global Surgery Days. So that's why I'm just kind of scrolling through all the general information. All of a sudden, it goes from portrait to landscape. Once it's in landscape, you're going to scroll down. Here's your data record. This one, if you continue down, you're looking at these. This is your columns. And what are we looking for? Well, Global Surgery. Here's where we talked about 0, 90, and 10 right here. Maternity, this doesn't apply. The global concept does not apply at all to XXS. If you see Y, this just means it's a carrier price, which means we'll determine it when we do the pricing. So the code itself is carrier priced, which means we require documentation and we'll determine it at that time. And ZZZ is usually used for add-on codes. So it's always incorporated somewhere else because an add-on code itself doesn't have a global date affecting it. Instead, it says, hey, this is an add-on to, et cetera, et cetera, et cetera. Go back to that code. That's what the ZZZ represents. But I also want to point out before we leave too far underneath here, when we come down into some of this information, we'll see bilateral, and I got to get down below multiple. Here's where we see modifier 50 and whether this applies to a code. So you can tell all of those different things, but it also say, hey, the adjustment doesn't apply, but it is bilateral. Some of these, it'll say it's not going to apply at all because the indicator or the description is for unilateral, or the description is for bilateral, therefore there's no payment rule applying. So bilateral will become important to understand in just a little bit. It's another column we may need to look at. Okay. So what does all this look like? Because I read you this stuff. What does it really look like? Let's go ahead and just open up the Excel file. Sorry, I had a second as to what this was. Now, what the Excel file is a CMS list for all relative value units. And again, it is broken out by column. So we're just waiting a second here. I don't know why this isn't opening for me. And so on that list, it does provide a lot of different information. Okay, so let's take a look at this once it opens up here. The reason that it's taking so long to open is the sheer size of it. Oh, it opened on the wrong screen. I'm waiting for it and it's on my other screen, which you guys cannot see. Okay, so here we go. Here's your procedure code. Here's a modifier. So sometimes a modifier will affect things, other times it will not, but if a modifier needs to be there, this is what it will tell you. Now in this case, I will tell you the modifiers that you're looking for are not affected by that column. So we're going to skip that column normally, but just that's what it is. We're going to come all the way over and you will see in column O, in this case, you're going to see a bunch of X's. This is where you'll find the 0, the 90, oops. So this is where you'll find things like the 0, the 90, the 10, which is why I pulled this one up because you can kind of see all the different days right in here. Okay. And it also tell you whether or not that bilateral surgery applies. We'll talk more about that. So sometimes you need to know, hey, it's bilateral, but I got to put a 50 on it. Yes or no? So that's where you're going to want to look at these indicators. So for instance, this one, it's bilateral 1. We'll talk more about what that means in a little bit, but I wanted you to have seen that column because it is something that we will talk about a little bit later in the presentation. Okay. All right, so you've seen where to find the files, all those different things that you might need to know there. Let's jump on back to our PowerPoint. Okay, so when we look at it, let's talk about these 3 modifiers. Now, again, these are what we're here to talk about. So if you gave me something else and it's not related to these 3 modifiers, I may not be answering that question today. So first, what is LT? LT is an anatomic modifier just like RT. LT, though, represents the left side of the body, while RT represents the right side of the body. So I'm talking 17 and 18 right together. Now, why do we specifically say that? We did have some very basic questions come in. You know, when do I want to use 50 versus RT-LT? What are we using for RT-LT opposed to 50? What procedure codes? You don't use modifier 50. There are some procedure codes that are written with a descriptor of a certain body side. Those you would not be able to use 50 on. They're very specifically written that way. So LT, RT. So you can use these on diagnostic and therapeutic services for unilateral services. In other words, something that doesn't specify right or left. It's a unilateral. Do not use when performing a bilateral service. You do want to consider doing a modifier 50 or bilateral indicators. The reason for that is depending on the indicator and depending on what's going on with the verbiage, you may not even need a modifier. So is it literally written as a bilateral service? If it is, and by course or by procedure code description, you don't need a modifier on that. So one of the common things we have happen is it'll come in, the description says that it's bilateral, and someone then tries to tell us, no, we just did the right. Well, the description doesn't allow for that. So it's a contradiction, which means you get an unprocessable, okay? So that's what that means when we talk about some of those different items. Modifier 50. Used for bilateral procedures at the same time in the same operative session. This is done when one surgeon is doing both. Someone did ask about it where they had a surgeon performing the right and a surgeon performing the left, and they were from different groups because of a complication that the patient has going on. That one, I'm going to tell you, you're going to want to use RT and LT if it's possible, because those physicians, we don't want to be hit up against each other within the processing system. And I'll explain that a little bit more when we get a little bit further in with that scenario. Okay. Keep in mind, if the description says bilateral in the CPT book, then you don't need to add a modifier 50. We already know it's bilateral. The description tells us that it's bilateral. If the description tells us that it's unilateral on the CPT book, then you want to use RT or LT, not 50, to say we did both. Tell us the side. Sometimes it means you're going to build 2 lines, one with RT, one with LT. So really when we look at it, those are the specifications. Okay. RT and LT are each reported with a single line item, 1. Now, modifier 50 is also reported with 1 on a unit. Don't report 2 on that unit. Modifier 50 doesn't represent that. Remember, if you report RT and LT or modifier 50, you will get 150% payment adjustment if it applies. That's part of what we just looked at when we looked at those files. So that's why you don't need to report 2 or 3 or whatever you're trying to do there. This causes the system to assign a procedure code and modifier denial or rejection. It just depends on how you are applying it. So we know that there are issues. 1 unit of service, a single unit of service for those services. So as we showed you back on that PDF document, there is a pricing indicator, and you want to make sure that you check the pricing indicator. 150 per, if you notice the 1 is highlighted, bolded, and it's got an equal sign. This is where your payment adjustment does apply for bilateral. It means you get 150% of the single fee. So if you do a right and a left together, you get 150%, not 200%. In other words, not 100% payments. That's why when it's defined as a unilateral, you need to be able RT and LT, because that can make you have the 2 payments that you need. So we want to make sure you're getting the correct thing. And when you look at that description, the correct payment comes from the definition. Okay. We'll talk more in just a couple of moments. The 0 means it doesn't apply at all, and the 9 means the bilateral payment doesn't apply either. So making sure that you're using that correctly, again, is the 1 is what we're looking for, and that's back on this Excel file, right? Here, I pointed it out before in this bilateral indicator column. Okay. All right. Again, you can use the physician fee schedule lookup. What is that, I was asked? So let's just briefly take a look at that. If instead of going into the actual relative value file in the physician fee schedule, which would be here, there's a lookup tool up at the top. And you can use this lookup tool, which is under Medicare again. And we're going to scroll through this to what? Payment, fee schedules. And then we're going to go to the physician fee schedule, which is where we're at right here. And this overview tool, it'll allow you to begin to search. You can enter you can accept a CPT agreement and enter in the information. You can add modifier information if you want to. You can say, no, I don't want that. I just want all general information. Great. And it'll give you all the different files. Okay. So if you wanted to take that and contrast it to this, if we did 11,451. Okay, so you can see that's this row. If we do that exact item here, we can say we just want to know about trying to find 05 if you're wondering what I'm doing. That's our contract for Iowa, 05102. We hit search fees. It'll give us the information we need for Iowa. Again, you can use any of these that you want, but if you scroll down and you move over, it'll look exactly like what you just saw without having to read the entire file. So just a nicer source or a nicer way of getting the information. But again, sometimes you want the entire file, sometimes you don't. I don't know what you're looking up there. It just kind of helps you a little bit. Okay. So what's happening? What's going on today that's causing this to continue to be an issue? Now, keep in mind, we did do education on this in 2023 at the beginning of 2023, and a lot of these issues appeared then, but are still continuing to be an issue. With Modifier 50, your codes are indicating bilateral, and I've said this like 6 times. What does your code indicate? What does your description indicate? But then you're saying, hey, by the way, I'm going to put a 50 on it. Well, that's going to cause an error in the system. The system is already expecting this to be priced for a bilateral procedure. It says I don't need anything more than that. Midline organs do not require modifier 50, and different areas of the same side of the body. Now, someone said, well, how does that work? We're not sure why it's being reported with a modifier 50, but an example of one that we did see was elbow and wrist. They were doing a surgery and it specifically listed elbow and wrist, and then they reported them with a modifier 50, except they weren't working on that. It's not documented as a right and left. It was documented all on the left side of the body. So when the documentation came in, we were like, wait, what? So again, there's the documentation that really does have to support it. And we'll talk more about that in just a few moments. All right, so don't append the modifier 50 to a midline organ, bilateral, uterus, esophagus, nasal septum. Now again, I shouldn't say 50, I should say RT, LT, or 50. That's not how this works. If you're doing something with any of these, it's one organ system. It's a midline organ system, and that's how it's referred to. Always take time to review the code descriptors. Look for the word bilateral, unilateral, or same side of the body. If it has those words, we don't necessarily need those modifiers. And in many cases, when it has those words, by appending the modifier, you're actually causing the problem, which means the claim is not going to process, and it's going to defeat the purpose of what you're trying to do with it. Also, if you look at the bilateral surgical indicators and you're seeing 0, 9, 3, 0, 2, 3, or 9, then don't use it. Remember I said, here's the one, this is the one that we paid 150%. That's the bilateral indicator that we're looking for. That's when you should use one of these three. Okay, that's what you want to do there. Remember, the 150% payment rule applies to the same physician, for the same surgery, for the same patient, on the same date of service. Same physician is defined as one physician within a group by tax ID with the same specialty. All right, let's keep going on here. I was asked a couple of questions on medically unlikely edits. I tried to give you the base information based on the questions that were asked, so hopefully I don't go too far into this. Isn't an MUE something that can affect a global surgery or a bilateral procedure? And the answer is yes. An MUE is medically unlikely edit is a max number of units that a provider can report in most circumstances. Now, an MUE is a per provider, per beneficiary, per data service, just similar to what one provider would be, except remember, it's one provider, one beneficiary, one data service. The MUE tables are broken up, so it could be the same claim, it could be the same data service, or it could be a once in a lifetime benefit. You'll have to check the tables. They don't have the same columns like the modifier column would be. So don't get confused and say, oh, wait, this isn't like the procedure to procedure and I got a modifier column. That's not what an MUE table will look like. So I want to make that clear. It does not mean that like a modifier 50 RT or LT couldn't override that. It can override it. So if you're doing a right and a left and the MUE is 1 and you put an R and a T on it, an LT and an RT on it, now you're indicating that you've done two separate sides of the body, which means yes, that's appropriate. Okay? So we want to make sure we're using that appropriately. If you put a 50 on it, you're still going to want to bill with one unit of service. A couple of resources for you that may help you out. Let me just show you where information would be located on this. Now remember, MUE is medically unlikely service, and it's part of the National Correct Coding Initiative. So we would go to Medicare, Coding and Billing. Then I said it was the National Correct Coding Initiative edits, right here in the middle. Once those edits open up, then you can see there's a variety of edits listed. Here's your add-on code edits, your medically unlikely current edits with your archive just above it, and your procedure to procedure. This is the one that you guys were asking me on. So then you want to scroll down and you want to make sure you're looking at the right set, whether it's the facility outpatient services or the practitioner, depending on who's billing. Let's use practitioner edits in this case. Again, we're just going to quickly save these. All right, so as this opens up, it's going to take just a moment. It appears. It's not opening at all for me. That's fun. As this opens up for me, there we go. You're going to see two different files. I'm just going to open the bottom one. It's going to list a number of MUEs, but it also is going to tell you per day. So if you're looking at a global period and you're like, if it is something that can be done only once in a day, you may need to append an RT and LT, right? So to see all these different MUEs, listed 1, listed 2, whatever the procedure codes are, you can go through and look and you'll be able to append a variety of different pieces of information, whether it's a data service, whether it's a line item, whatever it happens to be, that'll be here. So then it'll give you a code description and why. So this is actually CPT instructions. There is some that are not, that are going to be policy, but they're going to be CMS policy. There's going to be fraud and abuse by nature, clinical edit. So there's a variety of different reasons that MUEs are put in place. Okay. So read this. If you need to bill more than one, RT-LT will override this. So when you look at it, remember RT-LT will override it. Modifier 50 can be used if appropriate, and it will allow you to put a 1, but it will pay you at 150%. if that is a 1 on the Medicare physician fee schedule relative value unit file. So that's how the MUEs work. A little bit confusing, I know, it's just a lot to go over really quickly. So in MUE details, they reduce the claims error rate. That's the goal of them. Someone asks if the MUE was to reduce like anatomical variations or problems with that, and the answer is no, not really. It really is to make sure that things are done correctly. We are going to update those quarterly, just like the other ones where I said, hey, you're gonna have an A, B, C, and D. However, MUEs, when they're updated, it's one table set. Just keep in mind, 1 is a line item, may require a modifier. 2, no modifier allowed on this service above the listed MUE. And 3 means, by the way, there might be information that you may need to know, but what you're really looking for is that it's going to have to be given to us in an appeal. Okay. All right, lots of information given so far to answer a bunch of questions. These are more direct questions that I didn't build into those set of slides. So we're going to go through some question and answers, and then we'll open up for chat should we have time. So first question, how to explain to providers in an easy way about these modifiers? First, most providers are not interested in the modifier itself. What they're interested in is the documentation that supports the use of the modifier. So that's where you start. What did you do today? Well, I did an operation on the right side and the left side of the hand, right hand and left hand. Okay, does your documentation then support right and left? Okay, right and left wrist, right and left pointer finger, whatever the situation is. Okay, so it's really about, from their perspective, what's documented. The right was more complicated, the left was this, the right was this, the left was this. Can I look through each set of documentation and find what needs to be there? So we want to make sure that everything is done in that manner. Does that make sense? Hopefully it does. So when we really look at from a provider perspective, a lot of the providers that we've heard of say, well, I don't really care about this modifier thing. Well, what they're not understanding is that they may not care that it's modifier RT, LT, or 50. What they should care about is what's within the documentation to prove that their service was medically necessary on the right, left side, or that it should be done bilaterally. So that's really how I would impress it upon them. Just in case you're wondering, or in case you have any other explanations, let me know, which again, you can add some feedback. If you have a better way that works for you, please, we always want to hear that too. The next question that we really got was, how do I know if I can use 50 or should I use RT and LT? I want you to step back for 1 minute, go back to your code descriptors first. What is the code descriptor? Does the code descriptor say this is a bilateral procedure? Then you shouldn't use any. Does the code say it's unilateral, which means that you can only use RT and LT because you're telling us which side it occurred on? By the way, you do want to use RT and LT if you see a unilateral code. This can affect future payments should someone have to work on the other side of the body if we've already done it on that side. Because remember, some procedures are a once in a lifetime procedure, and if it's done, they shouldn't need it again on that side. So we want to make sure that we have all of this together. Okay. Also, look at the documentation. And I know that that sounds very basic to some people, but it is an issue that we have. We pull documentation, we have what we need, and next thing we know, we're like, wait, what? What do you mean? Well, it's not even documented. It's not here. We can't find it. If that's the case, we will reject the claim. If you have documentation you feel supports it and we've rejected it, you are welcome to appeal something like an overpayment or to move on to a second level of appeal. Any of that can happen. But you do want to point out on page blah, blah, with paragraph blah, blah, or, hey, we circled a section that we think highlights this or shows this or is important for this information for you. Sometimes there's just so much documentation sent that our providers, or I'm sorry, our review staff are unsure of what you're trying to get to. And so we aren't sure why you're using the RT-LT 50, why that combination should or should not be applied. I will tell you again, the documentation does not override a code description. If the code description says unilateral, you should not be putting a 50 on it. You should be putting an RT or an LT, or technically you could bill it with 2, right? It's a unilateral, so you bill it RT and LT. That's fine. I was asked specifically, the person believes they know the correct modifier to use. They just don't know if our system likes it. So what do they do? Now, if you don't know if our system likes a modifier you want to use, I would contact customer service, but I would ask that specific question. Does your system accept procedure code blah, 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 blah with modifier da, 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 da? That's what you're asking. Don't ask them how to code it. Don't ask them about coding advice. That they can't give you. But if you ask them specifically about a modifier code pair combination and does our system accept it, that they can normally answer, or that they can answer. When an obstetric, here's the next question. When an obstetric procedure is only done on one side, why would we be getting a denial for adding LT or RT to identify that it's only done on one side? I don't necessarily have this exact information. If you have a claim that is an example of this, send it to customer service. Here's some specifics about denials that are, here's some generalizations. One, does the global surgery period even apply to this? So yeah, we don't know that. Two, when you're only doing it on one side, is it a unilateral service? So RTLT not necessarily going to be there. Is the descriptor bilateral and you're appending something different? There's just too many procedures and things that go with this, and I don't want to try to speculate through. I would recommend that you obviously have a denial. You're telling me that. Contact customer service and say, we don't feel this denial is correct. Otherwise, use the tools that I've already shown you. The next question is, do Medicare Advantage plans follow the global surgery package? My answer to you is MA plans have different processing systems. What I'm giving you today is for Medicare fee-for-service Jurisdiction 5 and Jurisdiction 8, which is Iowa, Kansas, Missouri, Nebraska, and Indiana and Michigan. With that said, if it's an MA plan and it's not traditional fee-for-service, we can't answer the question. We don't know what they do and do not recognize. So I want to make sure we're aware of that. Can you use Modifier 50 and add-on codes? No. Modifier 50 isn't typically applied to an add-on code. I can't think of a single situation where this would be okay. The thing that I come up with that is it's an add-on code. Modifier 50 could be appended to the primary procedure, right? That would make sense. But why would you append it to the add-on code as well? So no. But again, if you have a specific scenario or codes that you want looked up, that can be done through customer service. Does Medicare prefer one claim item with 50 or two with the anatomic? It should be RT and LT. And Medicare doesn't have a preference as long as they're used correctly. So again, start back with the basics. Is it described as unilateral? Is it described as bilateral? What are we doing with it versus could it be 50 RT, LT? Is it the same physician? And again, remember using Medicare's definition of same physician. Is it the same patient? We have had some interesting coding errors come in where we're like, ooh, this shouldn't have been coded for that patient, but this one should have. Okay, in that case, you could have put an RT on one and an LT on the other, or whatever the situation was. So it was actually miscoded because the patient didn't have both procedures. It was two patients really being done. Typically, that happens when they have the same name, but maybe a different date of birth. So Medicare doesn't have a preference so long as you use them correctly. Our system doesn't prefer one over the other. That's definitely not what we're looking for there. I was asked about our website and what is available on our website. I think what you're talking about is going to be the modifiers fact sheet, and I'm not really sure when you say what is available or what does this mean. I'm not really entirely sure. So you might need to put some more information in chat on that one. So okay, things to keep in mind when we come to the WPS GHA website. We will go out and we will go to claims. Please make sure you're in line of business part B, either J8 or J5. Line of business simply means that you bill in a 1500 claim form or an 837P, and these are where the fact sheets will be for that information. Line of business A means that you bill in a UB04 or an 837I. This is where that information will be, but it's all located in the same area. So when you come out to I'm just going to use J5 Mac Part B. So line of business meaning 1500, 837P, Part B in Iowa, Kansas, Missouri, Nebraska. Okay, we're going to scroll down. We're going to look for a title called Modifiers. And what we're going to see is, oh, we only have one item. Well, okay, let's go ahead and open that item up. What we have is a modifier general page. So it explains a little bit about modifiers, but then it goes through and says, here's a whole lot of information you need to know. Okay, they're all broken out into multiple fact sheets. Here's bilateral, which is what we're talking about. And I'm hoping this is what you were getting at. So in the bilateral information fact sheet for 50, the additional information, it's all the way in the bottom. Sorry, here it is. For ambulatory surgery centers, and it talks about how to properly report for an ambulatory surgery center. I'm thinking this is what you were indicating. So it just says bilateral procedures furnished by an ASC must be covered under Part B. We know that. While use of 50 is not prohibited according to Medicare billing instruction, the modifier is not recognized for payment purposes if used, and it may result in incorrect payment. So that means we don't have a built-in edit that automatically says, no, this isn't right. It just might not pay correctly. So then it goes on to explain what we would like to see you do. Okay, what would we like to see you do? And this is how an ambulatory surgery center should bill for a bilateral procedure versus using modifier 50. Okay, so I'm thinking that's what you were talking about from the ambulatory surgery question in the modifier 50 fact sheet. I'm not entirely sure though. So if it isn't, let me know that in chat. Also though, we do have an RT and an LT, pretty basic information, things we already went over, but left side used to identify procedures on the left side of the body. Well, that's what LT means. And then these services can be on the right or left anatomical, okay, performed on the side of the body specific for a data service. It just says, okay, here's when you shouldn't use it. A procedure specifies bilateral or a side of the body. Well, this makes sense because if the procedure code description tells you it should be the right or the left, guess what? That's what we're going to follow. When surgical procedures are performed on both sides of the body on the same data service. This one would be what? Either by procedure code description bilateral or bilateral by 50. Okay. And again, then we wind up with RT giving us the same basic information. There we go. All right. I just saw a question pop in, and this might not be in proper order, but 66984, let's use that one for you. Not sure which tool you like to use, so let's come back here. CMS website, let's begin by just going to that payment, fee schedules, physician fee schedule. We're going to do a lookup, begin the search, accept the CPT agreement. Sorry, it takes a second. Now we're going to say, okay, we want this. I'm not sure what states you're in, but I don't want all MAC options. I only want to look up a specific MAC. This is where you're going to come through, and that's why I said J5 is Iowa, Kansas, Missouri, Nebraska, and then you have J8, which is Indiana or Michigan, and you can see I just scrolled by those ones. So let's do J5. Let's do Iowa again, just to keep it consistent. Here's your search results. So we know what it is. We get all the little descriptors. Can we go over? Does global surgery apply to start with? I'm trying to get over there for you, and it does. We know that it's a 90 days. We know that it is bilateral by nature, so we could use the 50, we could use the RT, we could use the LT, depending on it. This one means that there is, again, a payment adjustment. When you do it on both sides at the same time, it's 150% of the total fee. So you're not going to get 200, one for right, one for left, you'll get 150. But yes, you could use any of those modifiers. Now, again, that said, 66984, I don't know the full procedure code on that. I don't know that I can necessarily get it this way either, but we'll see. I don't see anything in this procedure code that says bilateral, unilateral, or anything like that. So again, yes, you could use any of those. So for whoever asked me that question, if you were to look at this in this procedure code by AMA, which is actually down here, were to say that it's got unilateral or bilateral within it, that would be a little bit different. I just don't see that in this one. So hopefully that answers your question on that. Let's see. Mary, do we have any other questions?
Tom, the only other question that we had thus far that is unanswered, and the one that was asked that I answered is in the chat, is that one of the learners is asking all of these great questions and answers that you're providing during this live webinar today. Will you be placing them into a separate question and answer document, or is the expectation that learners will come back to the recording to hear that?
Oh, great question. And we do expect that learners come back to the recording to hear that. We don't want to send out a question and answer document that could later change and then you've got the wrong information, but you still refer to our old one. What we will do is expect you to go to the recording. During that recording, you'll find information that's available. When that changes, we will take the recording down, so it'll no longer be available and you can't even get the incorrect information if something changes. For anyone who doesn't understand that comment, man, Medicare can change in a flat moment. I've literally been sitting in front of a group of 1,000 people, got a message saying, hey, at lunchtime, check this. Hopefully you haven't taught it yet, and discovered that my immediate item following lunch, which was at 1 o'clock, and lunch started at 11:15. Thank gosh there was another speaker in there, was wrong now. Wasn't wrong when I wrote it, was wrong now. So we try not to send anything out like that or put everything like that in writing. It gets to be really complex a message. On the other hand, we will make a recording. We'll leave the recording out there as long as it's relevant current information. Okay, anything else, Mary? Sorry. All right, I'm not here. Oh, Mary, anything?
Nothing at this time.
Okay, so just as a reminder, and I saw Mary put those dates in there, thank you for doing that. We do have an E&M and modifier usage coming up, and it'll go through a bunch of different modifiers related to E&M and the global surgery concept. It's not E&M overall, it's E&M and the global surgery concept. So if it's not an E&M modifier that affects the global surgery concept, we will not be talking about that modifier. There's also one coming up in January, or I'm sorry, in February. And that one's got a variety of modifiers in it. So please take a look at those. Again, Mary did put both of those in chat for you. Our next slide, just a resource slide, some different things you might find helpful. So take a look at any of these that you would like to know. Let's go ahead and keep going and finish right on up here. The survey is going to come out shortly. I'm going to have Mary put a link to that. Remember I talked about this? You can give me information on the survey. So what I'd like you to do, tell me what you liked about this webinar, tell me what you didn't like, tell me what you liked about the websites that I showed you, tell me all of those different things that are in there. And we want to make sure that we are well aware of what's going on with that. Now in this survey, if you say, hey, I'd also like to see education on, and it's not related to global surgery and it's not related to modifiers, cool. Just give me the feedback. We'll take that at any given time. We really just want to know how we're doing. Again, the link is in the chat. Another way you're going to get this survey is that I'm going to send you a follow-up email where it will be in there, and it's going to have a certificate. The certificate is contact hours, translates to CEU, but above the certificate, you will find a link to the survey. The last way is right here. It's going to be this little pop-up box on the right side, or on the left side, I'm sorry. It's going to have a little triangle at the top. It just says this is an external site. That's us. That's what we're asking you to go to take the survey. No big deal. And then we'll also give you an opportunity on any Encore to take the survey via the online. So lots going on there. Now, keep in mind, registration should be opening soon for January, February. Give it till about a month before, usually 30 to 40 days before the event, we open those. So coming up really quick. But again, provide feedback so we know if we need more modifier education, more global surgery education, exactly what we're looking for there. Medicare has started its annual participation agreement. So for those of you that have participated in Medicare, thank you. For those of you that don't want to change anything, you're done. If you've participated, you're good. If you haven't and you don't want to change, you're good. If you would like to either participate or not participate, and you're part of the physician fee schedule or other things, you can do your participation agreement now till the end of the year. So please make sure you get on that quick. Okay. All right, let's give you a couple of just fast reminders as we end up here. So first, You're going to get an email shortly. As I said, this will contain a link to the survey, but it will also contain a certificate on the bottom that has contact hours. We do not offer CEUs. Governing bodies offer CEUs, so AAPC, HEMA, any of those types of organizations. What we do is give you contact hours, which they can accept if they choose to for CEUs. It's on them how they want you to submit those. We don't have any control over that, but we will give you contact hours. If you are the person if you are the people that dialed in, then please make sure that you email us. I'll tell you about that in just a moment, but the information or the instructions are directly in the chat right now, and you just want to email just like you would a follow-up question. You get 7 days to do that, 7 days to ask for your survey. Make sure that you have global surgery in the subject line. If you are asking for a certificate because you dialed in, I do need a 10-digit call-in number. I need to be able to verify that. So area code plus remaining 7. Okay. With that said, thanks for listening. We appreciate your time today. We hope you got something out of it. We would encourage you to sign up for the remaining 2 global surgery concepts and global surgery modifier information coming out in January and February. Hopefully you'll get what you need from all of those. Again, please take this survey and we remind you to give us that feedback. On behalf of myself and Mary, thanks for your participation. We look forward to your survey comments and hope that you have a great day. Thanks, everyone.